As I mentioned earlier, our focus has always been to develop a better tolerated myeloablative regimen, preparatory regimen for transplant for older patients. And post-transplant Cy was the first step in that direction. Next, what we found was Thiotepa, when added to Busulfan and fludarabine, does allow for engraftment of haploidentical donor. Second, we saw that relapse rate was low in earlier studies. However, this was also associated with higher non-relapse mortality. So our goal was, could we optimize the dose of Busulfan and or Thiotepa to reduce non-relapse mortality while maintaining the reduced relapse rate? And so in our ongoing trial, we started 2 cohorts. So in one cohort, we reduced the dose of Thiotepa from 5 milligram per kilo to 2.5 milligram per kilo, leaving everything as is. Busulfan was given in a myeloablative doses at the area under the curve, 20,000. In the second cohort, what we did was we actually left Thiotepa dose at 5 milligrams, however increased the Busulfan dose to 20,000, or reduced the Busulfan dose to 16,000. So in one cohort we reduced the Busulfan dose, in the other cohort we reduced the Thiotepa dose. And we are presenting the results of both cohorts over here. The bottom line is the outcomes were similar. However, when we decided to enroll patients, we chose to enroll more older patients and patients with comorbidity on lower Busulfan or 16,000 Busulfan arm with 5 milligram per kilo of Thiotepa. And this resulted in similar outcome to the higher dose. And in fact, what was interesting, what we found was the full donor chimerism was, our 100% donor chimerism rate was significantly higher in the higher Thiotepa dose group and lower Busulfan group. So for all these reasons, even though the results are similar, but because they were obtained in older age group and patients with comorbidity with lower dose of Busulfan and 5 milligram per kilo of Thiotepa, that is the regimen we are taking forward in our future studies.